Okay, thank you everyone for joining the fourth annual International Day of Women in Statistics and Data Science. This session, session 204, is about rising stars, celebrating student-driven research. I'll just give it one more minute for everyone to join. So Lydia, you are going to be first. I'll stop sharing my screen. So if you want to share and then take it away, you are ready to go.
Awesome. Thank you so much. Share. Um, there we go. Can you see my screen?
Yes.
Awesome. Great. So good morning, everyone. My name is Lydia Owens, and I'm a third-year undergraduate studying biostatistics and mathematics at the University of North Carolina of Chapel Hill in the US. I'm really excited and grateful to get to share some of the work that I've been doing for the past 4 years about incarcerated healthcare in the US and show how health policy and biostats go hand in hand. So, most of my very early research career has hinged on this one question. How can we use data and modeling to protect the health and dignity of incarcerated people? This question is a culmination of my interest in law and policy, as well as statistics and data science. I got exposed to research as a profession in high school, and doing research over the past 4 years has taught me a lot about how statistics and data science work in the real world and impact the systems around us. I've worked on many projects trying to answer this question, but the one that I'm going to share with you today is the development of an agent-based model to model COVID-19 transmission within prisons. And so I hope this talk is useful to the larger reflection of how you can use statistics and data science and interdisciplinary research to shape change. So, to begin the story, I'm going to take you 5 years back to the COVID-19 pandemic. During the pandemic, when most schools and activities were suspended, I had the opportunity to complete a law internship with the Office of Rebecca Block, where I was working to help with expedited release for incarcerated clients with pre-existing health conditions. So, as you can see here in the graph, they were actually releasing less people during COVID than in prior years. So, it was a huge issue to get people out of prison that were very much at risk of death due to a new disease. So when the studies came out, it was actually found that incarcerated people in the US were 5 to 6 times more likely to be infected with COVID-19 and 2 to 3 times more likely to die from the disease. So in addition to working on expedited releases at the individual level, my internship group and I had the opportunity to meet on Capitol Hill with congressional representatives and pitch an Incarcerated Healthcare Reform Act, which was our broader systems level effort to increase access to necessary healthcare services in prisons to hopefully save more lives during COVID-19. But as we all know, in a few years, things opened back up, and as people moved on, I was still stuck on how we could utilize the data and lessons learned from this pandemic to make sure that something like this never happened again, and that some of the most marginalized and vulnerable populations in the US were better protected. So the year after the pandemic, I was accepted into a computational science program at my high school, as well as Harvard StatStart program, where I started learning about SIR transmission models and agent-based models and things like that. And I also realized that there was a database called the COVID Prison Project. It's a nationwide effort based at Duke University, which tracked all the COVID infections and deaths happening in all the prisons and jails around our country. So, combining these experiences, I decided to develop an agent-based model to model the COVID-19 transmission of multiple prisons. So, reading the literature, I realized there is a knowledge gap in prison-specific modeling. The current simulations that were predicting COVID-19 transmission in prisons weren't able to include characteristics about the prisons and about the issue about assuming homogeneous mixing of a prison population. That's actually a really pronounced issue considering when county jails and state facilities and federal prisons all differ in leadership and policy implementation, including health interventions. So many state and federal prisons implemented different solitary confinements, different lockdowns, and different policies to mitigate the spread of COVID-19 to where homogeneous mixing between populations wasn't a thing. And in addition, previous literature only modeled one prison in a paper at a time. So non-urban and less populous jails and prisons were excluded from the conversation or got missed in the modeling conversation. And what that means for real people's lives is that health interventions weren't as studied in these populations, and we weren't sure about the representativeness about the current studies in the literature. So what I did was I built an agent-based simulation model to predict COVID-19 transmission in prisons, where I could generalize the model while integrating facility-level characteristics as model parameters. And then I trained and tested this model on prisons of various sizes, geographical locations, and population profiles. And this helped me realize like whether the model was both accurate and representative to a large number of different populations. And so the model development, the model is an agent-based model. And for those of you who are not familiar with it, it's a type of stochastic modeling where you have a group of agents that have basic behaviors or different behaviors within a system. And those behaviors are governed by some set of parameters, which then allow you to predict their behavior, in this case, predict infection. And so a traditional SEIR model is a compartmental model that sorts these agents into four different groups. In this case, it was susceptible, exposed, infected, and recovered groups. And as the agents move through these groups, they go from being exposed to COVID-19, being infected with COVID-19, and eventually being recovered. And so the five different parameters that I looked at in my model were the latent period, which is how long it takes for COVID-19 to incubate in the body, the recovery period, which is how long it takes for people to recover from COVID-19, an initial case size metric, which you can think of like an outbreak metric, which was then calibrated to make sure that the average number that one person could infect, the average number of people that one person can infect, which is known as the R0 number, we wanted to make that accurate to empirical estimates. So we included an initial case size metric in this model. And then there was two others, the overcrowding metric, which takes into account the capacity of the prison and how overcapacity they are. And then finally, the vaccination rate of the incarcerated people in the prison. And so we decided to focus the model on two outcomes, which were the average daily infected rate of a given facility and the average daily recovery rate of the facility. And so we wanted to look at these two metrics because we believed that they would be most representative of how the model is overall doing, even with the number of agents or like the population sizes differing between prisons. And so we ran the model. We ran about 100,000 simulations of different parameter combinations, all being properly sampled from distributions based on literature. And we also ran a sensitivity analysis because we wanted to figure out which one of these parameters or which of these parameters were most important and what they were doing within the model so that it wasn't like a black box model and we could actually see what was going on. And so we realized that vaccination rate was the most important non-biological parameter in terms of preventing infection, which kind of makes sense. And we also realized that the initial case size, so the amount of patient zeros that were in a prison or jail at any given time, was also very important to modeling when looking at the non-biological factors. And this makes sense as like prisons and jails usually have a lot of turnover, a lot of people coming in and out every day to where if you had an initial case size of like 5 or 6 people, this would be really devastating on the prison, even if those people didn't stay within the prison. And so looking at our results, we use something called a MAPE, which is a mean average percentage error. So basically, it aggregates for the testing sets, the observed average infected and recovered rates, the difference between those and the simulated average infected rates. And it puts it into one score for each facility for the model so we can see how our overall forecasting is doing. And we found that most of the facilities had highly accurate or good forecasting. And we also included a facility that had bad data, essentially, or data that wasn't very transparent or multiple entries of the same exact infected or recovered population for long stretches, like months of time, just to show how data transparency worked into the model. And of course, this prison had weak and inaccurate forecasting, which brings me to the discussion about how important data transparency is when working with real world issues like this. It was a big lift and heavy effort of many people to create the COVID prison project and to work with departments of corrections and people like that to make sure that data was getting accurately collected. And we saw that this wasn't happening in every place and every time. And so health interventions really couldn't be modeled for these populations. Um, But beyond that, we saw that vaccination, which is a policy-based effort, was also extremely important, and that increasing vaccination rates and reducing overcrowding were found to be key strategies to mitigate COVID-19 transmission, specifically within prisons. And while we didn't incorporate staff dynamics, population turnover, or comprehensive statewide data, we think that all of those things could be included in the model moving forward. And so this is my conclusion. Just I want to finish up by saying that incorporating facility level characteristics is important to forecast for prison modeling, and flexible multi-facility modeling is possible when combined with transparent and consistent data. So thank you so much. Those are my references.
Okay, thank you so much, Lydia. Great presentation. Our next speaker is going to be Daniel Hoberman, so take it away whenever you're ready.
Thank you. Let me just share here. Are you guys able to see?
Yep.
Okay, awesome. Good morning, everyone. Thank you, Lydia. That was actually really interesting. I'm gonna have to follow up. I just took a ton of notes, but thank you, everyone, especially the organizers, for coming today. I'm really honored to be here, and I've been inspired a lot by what I've seen so far in the conference. A little bit about me. My name is Daniel Hoberman, and I'm a senior at St. Anthony's High School in South Huntington, New York, in the US. And today I'll be presenting my research on the relationship between access to healthy foods and depression across southeastern Pennsylvania. So, prior literature consistently seems to link diet quality to mental health. So, anti-inflammatory diets that are rich in fruits, vegetables, and whole grains have been shown to reduce inflammation and oxidative stress in the mood-related brain regions, which will then improve overall mental well-being. However, maintaining this healthy diet isn't purely a personal choice. It's also dependent on the access that one has. So, if a community lacks healthy food options, people are less likely to eat nutritious diets, which can then worsen mental health outcomes. So this access to healthy foods is then not even across the US. So where healthy food retailers open is going to depend on certain neighborhood characteristics such as race, poverty, and urbanicity. And the literature also showed that predominantly Black and low-income neighborhoods often face what was called a double jeopardy, in that they have limited access to nutritious options and then very high exposure to fast food. So all of this was to say that policies should be locally tailored and not really a one size fits all type thing. So in order to measure food access, we start by defining each census tract as a neighborhood, since that was the smallest geographical scale at which the data were publicly available. So for each tract, we're going to identify its population center as an anchor point, and then measure the distance to the nearest healthy food retailer from there. So there are two main ways that we measure this distance. We use the Haversine distance, which is more of like a straight line calculation between 2 points, and it's very simple and easy to calculate, but it's going to ignore roads, rivers, and any type of geographical barrier. And then on the other hand, we have our route-based distances, which come from Google Maps. And those are going to follow real driving paths and reflect actual travel time, but they're very computationally expensive to calculate. So here's a little bit about why that difference matters. If we look at our example here, we have this neighborhood on the right and this healthy food retailer on the left, and we see that the Haversine method reports a 4 mile distance. However, the actual route is nearly 19 miles because that Susquehanna River blocks direct travel. So in this case, you'd actually be required to travel through another state to get to that healthy food retailer. So this kind of underestimate is what leads to misclassification when they label areas that they have access when in reality they do not. So lastly, we have to convert those distances into categories. So if a tract has a healthy food retailer within half a mile, we'll call that high access. Within 1 mile, we'll call that moderate access. And then beyond 1 mile, we're going to call that low access. And these cutoffs match the USDA definitions, and they allow us to create binary indicators. So 1 for access within a radius and 0 for no access. So moving on to our study specifically, our goal was to analyze how proximity to healthy food retailers relates to depression prevalence across southeastern Pennsylvania. So we studied 1,740 census tracts across 10 counties in the region, and that represented urban, suburban, and rural communities. And we were able to calculate Haversine distances for every single tract, while route-based distances, because they're so computationally expensive, we collected those for a random subset of 525 tracts. And so we see at using the Haversine, the error-prone exposure, about 39% of tracks lacked access at the half-mile radius, and at the 1 mile radius, about 18% of tracks lacked access. So if we look how that looks across the region visually, we see that here, and all of our figures were plotted in R using ggplot. And then when we compare that to the route-based distances, we find that roughly 13% of those queried tracks were misclassified, and this misclassification is going to motivate the statistical correction that we'll use later. So if we transition into a little bit more of the math side of the analysis, we're going to observe the 4 following variables in any tract. So we have y, x, x star, and z. So y is a count of the number of adults with depression in a given tract. And we pulled this data from the CDC Places database of the 2020 release. And then we used R to plot this across the state. So that's shown over here, just to see how depression looks visually across the region. And then X is our true exposure indicator. So because we only queried those 525 tracks, we're only going to observe X in tracks that were queried for the route-based distance calculation. And we're going to observe X at both the 1 mile and the half-mile radius. And we were able to call the Google Maps API using the ggmap function package in R. Then we have X star, which was our error-prone exposure indicator. So we're able to observe X star in all tracks because we can calculate those Haversine distances for every single tract. And the food stores that we used came from the USDA SNAP program. And then we processed these distances in R using the Geosphere package. Lastly, we have Z, which is a vector of all of our different covariates to control for in our analysis. So the ones that we selected were unemployment rate, percent single parent household, percent rent occupied housing, percent of employees taking public transportation, and then population density. And we pulled these data from the US Census Bureau's American Community Survey using the Tidy Census package. So now we move into our 3 different Poisson regression models that we applied. So the naive model is going to use the Haversine exposure X star for every tract, and it's going to ignore any type of measurement error. So again, since Y is a count as well, we offset this by taking the log of the population in order to make it into a prevalence. Then we have our complete case model, which uses only tracks where the route-based exposure X was available. And this is going to reduce the bias that's present in the error-prone naive model, but we're also throwing out over 1,000 tracks of our sample size because we only have those 525 tracks that we observe X in. And then lastly, the MLE model combines both. It's going to use X and X star if they're both known, but if X is not known, we're just going to use X star. And this was implemented through the Possum R package. And the MLE is going to recover the efficiency that we lost in the complete case, but reduce the bias present in the naive model. And this is also observed in simulations as described in prior literature. So we fit all 3 models at both distance thresholds, and each model is going to output a prevalence ratio, which tells us the predicted difference in prevalence for tracks with and without access when we control for all of our covariates. So for example, a prevalence ratio of 1.05 would indicate a 5% higher predicted prevalence in a tract with access compared to one without. And we calculate these ratios by exponentiating the coefficient that's attached to our exposure variable in the model output. So we call that beta 1. So we see at the half-mile threshold, all of our prevalence ratios are above 1, meaning that tracts with nearby food access also show higher depression prevalence. The naive model gives us a prevalence ratio of about 1.01 with pretty narrow confidence intervals, but a likely downward bias. The complete case model gives us a prevalence ratio of 1.04, but with a lot higher variability due to that lower sample size due to the fewer tracks. And then the MLE model produces 1.12 with the lowest variability, which shows a little bit greater stability when we correct for that measurement error. At the 1 mile threshold, the naive model drops actually slightly below 1 to around 0.98, which suggests slightly lower depression with access. However, the complete case and MLE models again exceed 1, with the MLE staying consistent at that 1.12. And that consistency across radii could suggest that accounting for that measurement error could yield a little bit more reliable results. So it's important not to overinterpret the prevalence ratios greater than 1. They're not meaning that access causes higher depression, but rather that tracts with high access are often urban, where noise, traffic, crowding, and poverty levels could elevate stress levels. And then also proximity is not going to guarantee affordability or quality. Stores in low income areas have been shown to sell fresh fewer fresh options and at higher prices. And then finally, food retailers often cluster in those dense areas where depression rates are already high, which could be a source of confounding. So overall, increasing the number of stores alone likely won't be enough to improve our mental health. Policy should instead focus on affordability, cultural fit, and quality of food options. From more of a methods perspective, we found that using route-based measures yields more accurate and unbiased results. So in the future, scaling route-based queries statewide could create a full gold standard dataset to compare the three competing models to. And then lastly, future work could include walking or transit access, as well as extend to other mental health outcomes for a bit of a more comprehensive picture. All right, thank you very much. Just a couple of thank yous here. I just really want to thank Ashley Mullan. I couldn't have done any of this without her. She taught me R from the very basics all the way to running these Poisson models. Couldn't have done it without her. She's amazing. Thank you so much. And then Mr. Paul Pano for putting me in contact with Ashley and supporting me throughout this whole thing. And here are my references. Thank you so much.
All right, thank you so much, Danny, for that great presentation. Our next speaker is Carrie LaBarca, so take it away when you're ready.
Let me try to share my screen. Can you see it?
Yes.
Thank you. Hello, thank you, Ms. Hannah, for that introduction. Thank you. I'm so excited to be here today. Hello, my name is Carrie LaBarca. I'm a junior at St. Anthony's High School, and my project is a descriptive study on exploring dental clinic visit trends in the United States. First, I will be going over the introduction, then I'm going to dive into the methods and results, and finally, I'm going to share what I took away from this. We'll start with the introduction. Dental visits are important to prevent dental issues such as tooth loss, gum disease, and even systemic diseases. Systemic disease is a medical condition that affects the entire body or multiple systems. There are multiple studies that show that and have analyzed how dental visits lead to better oral health and therefore an increase in dental issues, a decrease in dental issues, sorry. In this study, we will find that factors may affect dental clinic visit rates in the United States, and I've created maps and graphs that will be used to analyze this data. Now moving on to the methods. The data set were collected from the Centers for Disease Control and Prevention, also known as CDC, with the use of the Behavioral Risk Factor Surveillance System, which are telephone surveys that are sent out to different people's telephones and landlines, and then that's how they answer the surveys and they get the data. The data provided shows the percentage of adults in each state based on a specific subgroup who reported going to the dentist from even years from 2012 to 2025, but I will be looking at specifically 2016. Percentages were broken into multiple subgroups, but I'm specifically looking at 4 of them, which is age, gender, income, and education. And here are my results. So this graph shows the percentage of adults age 18 to 24 and 65 plus that reported a dentist visit in 2016. Overall, the two groups are very similar, but the 18 to 24 age group does have higher percentages. This map shows the percentage of age 18 to 24 adults who visited a dental clinic in 2016 compared to the national average of the United States, which is about 70%, but 69%. Most of the states are below the national average. However, the states that are above tend to be in clusters, as you can see in the Midwestern and Northeastern areas. These two graphs gives us a closer look into the specific percentages for adults 18 to 24 and 65 plus per state. As you can see, the darker color on the left graph, the darker the color is, the lower the percentage of visit rates. We can see that Oklahoma by far has the lowest percentage rate, which is 55.1. And the state with the highest percentage is Rhode Island with the percentages of 80.8%. On the map on the right, they show the same thing, but in a more general range. As you can see, the percentage ranges from 0 to 100. We can see that there is some variation between the states in both maps, but these maps confirm the observation that there is not much variation between the two subgroups. This graph shows the relationship between the percentage of adults that report a dentist visit and gender. Overall, the two groups are similar, but females tend to have a little bit higher visit rate than males. This graph shows the percentage of adults who go to dental clinic visits based on their income. Income has a much clearer effect than the other factors that we've seen thus far. Adults with a higher income tend to have a higher percent of visit rates than adults with a lower income. I also noticed that the two data sets, less than $15,000 and $15,000 to $24,999, have the widest range of about 35%, while the other incomes have a much smaller range. Now, if we take a closer look at the income groups on the extreme ends of the scale, we see how the left map is a much darker blue than compared to the right map, showing how adults with low income compared to those with over 50,000 are less likely to go to dental visits. Lastly, this graph shows the percentage of adults who go to dental visits based on the level of education. Adults with a lower education, less than high school, are shown to have lower percentages, while those with a higher education tend to have higher percentage of dental visit rates. Finally, these are the things that you should take away from this presentation. So dental clinic visit rates usually differ when looking at the subgroups of income and education level, while age and gender have a less pronounced difference. They're there, but they're not as pronounced. Some of the limitations may include granularity or the level of detail in the data that can be improved upon by looking at individual people instead of groups. The survey could also be prone to bias because the data can only be collected if adults answer the telephone and complete the survey. So that would definitely change the survey size. So the future direction for this project is to explore if there are any other factors that could affect the percentage of visits of adults that visit. Like, for example, race was one of the other subgroups that I didn't dive into, but that could be one. I would also like to conduct a deeper study with a smaller population to obtain higher granularity data and possibly see if any of these factors have an even more pronounced effect. I would just like to thank my mentor, Miss Ashley Mullan, who helped me so much with this project, and especially learning the R coding to make these graphs. And my teacher, Mr. Paul Pano, who I wouldn't have been able to do any of this without. And they both helped me with my success in this project. Here are my references. And thank you so much for your time.
All right, thank you so much, Carrie, for another great presentation. So our final speaker for this session is going to be Miriam Vanderwater. So whenever you're ready, Miriam, you can take it away.
Guys, can you guys hear me? Sorry.
Yes.
Okay, perfect.
We just can't see your screen right now.
Okay, sorry. Okay, can you see my presentation? Sorry.
Yes.
Okay, if I put this in presenter view, please let me know if you can see.
Yeah, we can see the presenter view right now.
Okay, it's fine. Sans notes. Okay, so hi everyone, sorry about that. My name is Miriam Vanderwater. I am a first-year PhD student at the North Carolina State University. And I'm presenting on my undergraduate research. This was my thesis project. So it was very long. This is kind of the distilled version. I completed this at mine and Ms. Ashley Mullan's alma mater, the University of Scranton. Okay, so to dive right in, Here are two definitions that it's important for you guys to know down. The first is collective decision making, which is pretty much exactly what it sounds like. It's this process where we have a population and they're making a decision collectively through some sort of rule, which in my case is a majority rule. So like if over half of the population makes a choice, then that will be applied to the entire population. The second is sociality, which is just this really loose term that describes the interactions between members of a population. Okay, so really quick, so you have some sort of direction about where this is going. Here's my formal goal and corresponding research question. It's kind of wordy. So basically, I wanted to explore the long-term effects of both CDM and sociality, which I did by making a simulation model. So in general, how do we represent decisions mathematically? Well, we do so in a probability framework. In particular, conditional probabilities allow us to include the effects of other factors like social and environmental influences on the probability of making a specific choice. The decision equation that I used in my project was developed by Arganda et al. In 2012. And we're going to briefly run through their derivation because it provides a nice setup for the simulation I built. And also it's like the most statistics-y part of my project. So they begin by assuming that our population is choosing between only two choices, just to simplify matters, and we call those X and Y. Furthermore, one of the options is going to be better than the other, and by that we mean that it will afford some sort of greater fitness than the other. And also that the individual is in a population in which they can, but they don't have to have knowledge of the choices of others. So what the authors did in this paper was they used this principle called probability matching to develop this general ratio to represent the probability that an individual is going to select this option X. And so I just wanted to note that this probability that X is good in a biological context can refer to things like the presence of food, the absence of shelter, or presence of food or shelter, or the absence of predators. But the question is, what is this probability that X or Y is good? And you're gonna have to believe me on this one, that this is the equation that they came up with. They did so using a lot of conditional probability and specifically Bayes' theorem to develop this equation. And that just says that the probability of making a choice given non-social and social information is equal to this ratio 1/1 plus AX and then the rest, where A is this non-social term, S is a reliability term of communication between the individuals, and K is a relative impact term. And X and NY are the number of individuals that have made this choice, and those numbers will be updated as the simulation runs. We can plug it all in. So there's number one is the equation you saw before, number two is the one from the previous slide, and then the equation that Y is good is just the same thing with the subscripts switched. And then we do that, we get this nasty looking equation, which using some inverse laws can be reformed into that, which is slightly less ugly. Since we're dealing with probabilities and just two options, the probability of making the other choice is just 1 minus the first probability. So why does this equation matter? Well, now we have an equation to represent the probability that an individual is going to choose option X, which is the equation that I used in my simulation. Okay, so getting into the methodology a little bit, I want to begin with how I categorize the populations. So considering both CDM and sociality, we can assume that a population either has them or they don't. So I claim that if a population does have CDM, then whatever the majority of the population chooses is applied to everyone. So if 52% of them chose option X, then everyone's going to choose option X. And I denote that with a majority selection. On the other hand, if they don't have CDM, then the population is going to remain divided amongst whatever percentages chose X or Y with an individual selection. Now, sociality, is that individuals who have already chosen have the ability to influence the probability of potential choosers making a choice between X or Y. And so if you recall that equation, that just means that S has to be greater than 1. That enables the NX and the NY terms to have an impact on the probability. If they don't have sociality, then individuals who have already chosen, so that NX and NY term, we want them to be negligible, so we just set S equal to 1. Okay, so that leads me to my experiments. So what I was doing is I'm putting populations in competition with one another, and I wanted to do so where each experiment was a unique combination of competing populations. And so if we have over here like the summary of the last slide where we just have an M or an I or an S or an N representing the categories, we get these this breakdown of experiments, and we would be here literally all day if I talked about each one. So I'm just going to focus on experiment 6, which is, in my opinion, the most interesting and revealing. Okay, so the general pipeline for the simulation, I implemented this in Julia using kind of some base code from my advisor's collaborator at NJIT. So I just embedded that equation into a model of population dynamics, specifically logistic growth, meaning that it contains a carrying capacity term. I ran it for several time steps or rounds, which was usually around 100 to reach a plateau for each population. And at each time step, there was a cost or a benefit that altered the number of deaths or births for each population. The cost is just a probability that an individual choosing the wrong option is going to die. And a benefit is the probability that an individual choosing the better option is going to reproduce. So that's going to either raise or lower the population. The benefit was scaled by carrying capacity to introduce the competition that I wanted. Due to the stochasticity of this whole thing and how many probabilities were involved, I repeated each time experiment 25 times with the exact same parameters. And then to test kind of a large grid of parameters, I did this over several combinations. Okay, so really quick before I display my results, I want to note exactly what I measured. I was interested in the long-term effects, so I just took data from the last time step to compute this ratio between the two populations. So anything greater than 1 implies that population 1 outperformed population 2, and anything less than 1 would imply that population 2 outperformed population 1. However, it is not unreasonable to think that population 2 might go to extinction, so that would put a 0 in our denominator, which we don't want, so I scale it by carrying capacity. So for experiment 6 in particular, that puts the MS population on the top. Okay, so I chose to represent my data in 2 different ways. The first is this histogram of all the trials to display the frequency of the scaled ratio. And the second is this heat map here showing the mean scaled ratio as a function of the parameter A and S, where each subplot corresponds to a different K. So the darker values are where the scaled ratio is greater than 1. So that means that population 1 outperformed population 2. And then the lighter values are where our population 2, which is in this case the individual non-social population, outperforms the population 1. It's pretty clear from both plots here that the MS population is favored in almost all situations, except those when K is equal to 0. You can see that especially in this pink colored subplot corresponding to when K is equal to 0. Okay, so to offer an explanation for that deviation at K equals 0, we can return to its context in the Arganda equation and its definition, which is the relative impact of choosing one option over another. When K is equal to 0, the animals at one option do not seem to have information about the other option. That is, they promote their choice, but fail to discourage the other one. So if we look specifically at this diagram to represent the probability of choosing X as a function of those who have already chosen X and Y, we can notice this large probability plateau of 1/2, which is this large green region there for the k equals 0 case. And in any given decision time step, a large amount of the population does have to be clustered at one option to significantly deviate that probability away from 1/2. If this doesn't happen, then we can imagine that our population will be split nearly half and half between the two options, which is only going to impact the majority social population as they have that S term, which will then include the K term. Which means that in a lot of situations, they're going to have a 50% chance of making the wrong choice, which is relatively high. However, this does not affect the IN population, and their probability of thinking that X is good is going to be simplified to this, which just relies on non-social information. So they're not going to be negatively impacted by this plateau at k equals 0. Okay, so that is kind of a lot to parse through, and it's a little bit hard to interpret these results. So I'm just going to give you like this main takeaway, which is that collective decision-making and sociality do improve fitness in populations where individuals are informed about both the good as well as the bad impacts of potential options. Okay. And here are my references. And I wanted to acknowledge my advisor, Dr. Graham at the University of Scranton, the committee members who reviewed my thesis and helped me out a lot with it, our collaborator, Dr. Garnier from NJIT, the honors program who supported me in this project, and just everyone else who supported me. Thank you so much.
Okay, thank you so much, Miriam. We have a few minutes left in this session. If anyone had any questions that they wanted to pop in the Q&A, a few of our speakers did have to jump off. Miriam's still here though, if anyone has any questions.
Yeah, I know that was a lot. It's kind of a thick project, and I was like trying to distill it all down.
No, you did a great job, and it was really interesting.
I should have acknowledged Ashley as well on here because she was super supportive in just the whole research project. So yeah, another shout out to Miss Ashley Mullan.
All right, well, if there aren't any questions, we can wrap this up and maybe just take a minute and then come back for our next session. Okay, again, thank you so much to all of our speakers for this session. Everyone had amazing talks.